Happy Heart Month, and welcome to our Valentine's celebration. Thank you all for joining us today. I'm pleased to share that today's event has been awarded CME credits. This program is brought to you by Georgia Heart Institute. The planners and speaker have disclosed no relevant financial relationships with commercial interests. If you have a question for our speaker, please hold until the end of the questions and answers segment of the presentation. Your input is important to us. Please take our online survey. The link to that will be shared at the end of the program and in the Zoom chat. And now, it is my pleasure to introduce our speaker, Dr. Egolum.
All right. Thanks everyone. Really excited to see all our LVAD patients, nurses. A lot of this was, Julie's idea along with the whole team, but the whole Valentine thing was really just an opportunity to celebrate the growth we've had in the program, celebrate our patients, and for you guys to come back and we'll see how great and wonderful you guys are doing. And really, as we know about LVAD therapy, it's really a multidisciplinary team effort. It's teamwork. It really touches every aspect of our health system. And I think it's really a microcosm of our health system and the growth and trajectory that it's had over the last several years. And it really symbolizes where the health system is headed, where it's been, and what the future holds. So what I'm going to do is just briefly talk about LVAD therapy and then go over some important pointers, I think. All right, so really what we'll talk about, I'll review the incidence of heart failure and the prevalence of heart failure. Why is LVAD therapy important? And then just briefly look at a history of LVAD therapy at Northeast Georgia Health System and give a highlight of some of our LVAD outcomes that we've had so far. So when we talk about heart failure, I know for a while everyone's been focused on the COVID epidemic and pandemic, but for a really long time we've had a heart failure pandemic, right? It's just not as obvious to people as they look around and things, but current estimates are up to close to 7 million adults in the US have heart failure. And that number is going to easily climb to 10 million over the next several years. 1 in 9 deaths in the United States is a result of heart failure. So that's a lot of patients that died that have this disease. And unfortunately, despite all the medical therapies and options we have, about half of the patients that have heart failure die within 5 years. And the estimated financial cost is close to $31 billion. And that number continues to rise. When we discuss heart failure, there's a pathway that a lot of patients go through. If you look towards the left of the slide, initially the diagnosis is made, the patient gets on treatment. But for a lot of patients, they may stabilize for a while. But if you look at the blue line, some patients gradually, progressively have worsening heart failure. And then within that window that we have there, we talk about this golden window, where as a patient starts to decline, this is a time we can get in and actually provide specific therapies to help prolong their lives and have them have a better quality of life. So this is really what my specialty as an advanced heart failure cardiologist is designed to do. And this is actually what the health system is also in place for, identifying the patients that do progress and need that life-saving therapy. So once patients start going through this process of that gradual decline, we really need to identify them and immediately initiate therapy. So for those folks who are in the audience and they're clinicians, whether you're a nurse practitioner, physician, this is a mnemonic that we commonly use to be able to identify which subgroup of heart failure patients have gotten to the point where they need advanced therapies such as LVAD or heart transplant. So we call this the I need help mnemonic. And the I means IV inotropes. So any patient with heart failure that ends up on inotropic support to help their heart keep pumping should be evaluated for this. Patients that have really bad heart failure, that despite medical therapy, they still have a lot of symptoms and they're back and forth to the hospital, qualify for this as well. When we start seeing dysfunction of the end organs, so for example, kidney function, liver function, if those numbers are gradually becoming abnormal, that again tells us that we ought to look for advanced therapies. If the patient has consistent fluid buildup and we give them diuretics and we're just not getting the fluid off, that's another indication. Patients that have really low blood pressures, especially if we're having to take them off the heart failure treatment therapy, is another indication that these patients need to be evaluated for this. So I'm sure as we talk to many of our heart failure patients, many of them suffered and had these symptoms for a while until we were able to proceed with LVAD therapy and help them have a better quality of life. So again, when we talk about heart failure, we mentioned that 6 million plus number, but not all those patients develop advanced heart failure where they need an LVAD. The current estimates is roughly there's about 62,000 patients that probably would benefit from LVAD therapy. But what we've noticed, and this is nationwide, roughly only 10% of that number actually gets advanced therapies. So in the United States, roughly we're doing 4,000 to 5,000 LVADs. And again, the need there is about 62,000 patients. Patients potentially could qualify. And the unfortunate reality is that at most places or other centers, a lot of these patients die without being offered life-saving therapy related to LVAD. So really, this is one of the missions we have to really get this therapy out there in the community, engage with thought leaders, engage with primary care doctors, nurses, and whoever sees patients to make sure we're in a timely manner within that window of opportunity we're referring the patients in so they can potentially benefit from this therapeutic intervention. In the current era, looking at 2023 and beyond, there's really one main heart pump that we're currently using. This is the main one that's available in the community, and this is what's currently FDA approved, and this is called HeartMate 3 LVAD. And as you guys mingle around, you'll see that all of our patients pretty much have this pump. The pump has several aspects to it. If we look towards the middle, we see that the pump is implanted through a surgical approach. The pump is put in. On the outside, you can see the controller and then the battery pack that's attached to the patient. There's a drive line that exits the body and attaches to the controller and then through that to the batteries. And with this system set up, it allows the patient to live an active lifestyle. So a lot of the basic things the patient was not able to do before, they're now able to do it. So here's the data from the HeartMate 3, right? So this was studied and they looked at patients who had the pump implanted and we wanted to see how well they were doing. And these are required data points that need to be provided to the FDA. So at 2-year survival is 80%. Now, without advanced heart failure therapies or LVAD, most patients with heart failure at 2 years would not be here. Perhaps the survival would be 10%, 15%. So really, you can take the chances of a patient being alive versus not and get it up as high as 80% at 2 years. So really life-changing data here because none of the prior pumps had this level of support in terms of having evidence to support its care for patients. So that's survival. But not only that, one of the most important things for patients, patients want to live, but they really want to live, right? They want to do things. They want to go with the grandkids. If they hunt, they want to be able to hunt. So basic things like moving around and improving the quality of life is also an important part. And this is what we've seen with this heart pump. So the KCCQ score is really a way to quantify how well a patient is doing in terms of how they see their life and quality of life. And most of the patients that have this pump implanted have a 30-point increase in that number, which is pretty significant when we look at it. When we look further to the right part of the slide, we can see there's a significant improvement in the patient's 6-minute walk distance, meaning that patient now, some patients prior to this may have been able to walk only 20 feet and then they have to sit and rest. But now that patient who could not walk from the parking lot into the clinic, they're able to do that. They can get up and walk and brush their teeth, put clothes on. So really the basic things in life, things that they're able to do as it improves their quality of life and adds much more to it. And the great thing with this pump as well, we're achieving these really good outcomes with lower risks of complications, so less strokes, and virtually no pump clots are formed with this pump, so much better than the prior generation of this pump. Now, as we've looked at the data, we now have the 5-year data available. So yes, at 2 years, we know patients live longer, good quality of life. But 3 years on, are we seeing the same thing? And yes, the data is pretty clear. 5 years on, up to 60% of patients are still alive, which is, again, great. Because if this was run-of-the-mill heart failure and no treatment options, virtually 0% of the patients will be alive at this point. So the fact that we're able to achieve this 60% is really a monumental jump in the care of patients with heart failure. Additionally, they continue to have improved walk distance and they continue to report improved quality of life. So we see this at the 2-year mark, but also we're seeing this 5 years on and we're waiting to keep seeing it 6, 7, 8 years down the line as we go along. So very important to show that. Now, within the context that we practice, we try to do everything along the lines of evidence-based guidelines and recommendations from the societies that govern our practices and stuff. And this is the most recent guidelines from the 2022 AHA, ACC, HFSA guidelines. And now it has a strong recommendation that for patients who have heart failure and require inotropic support, that we should proceed to have LVAD therapy offered to those patients rather than patients going home on inotropes and living with that. This is a much better option. It's even moved further now. What we're saying is even if the patient doesn't have inotropic support or need primary core dobutamine, if someone has severe recurrent heart failure and they're short of breath, recurrent episodes of heart failure, they also qualify for LVAD. We do not have to wait till the patient is in extremis and not doing well before we proceed to LVAD. So now our clinical guidelines, because we have enough evidence, strongly suggest this, and now this is a standard of care as to how we practice and take care of patients. So very important that that message is out there. So I'm going to turn a little bit and pivot to our heart failure LVAD program here at Northeast Georgia. So really our LVAD program kicked off in 2018, but prior to that, the good 3, 4, 5 years, there's a lot of work done in the background with our prior leadership, physician leadership team back then, our anesthesiologists, finance people, admin, really big team, and a lot of discussions got to that point where eventually the LVAD program took off in 2018. So this just shows the amount of LVADs we've implanted on a quarterly basis. And so far, I would say, really great outcomes. And we've gotten to the point where we have a total of 55 patients have been implanted with our LVADs thus far. So really incremental growth and development for the program. So earlier I showed the data as it relates to the 6-minute walk test in the clinical trials with HeartMate 3. Well, as we look at our data, here we're tracking, percentage of our patients who had an improvement in that 6-minute walk time. And we see 25% improvement as being clinically significant. And you could tell, if you look at that lighter green bar, roughly 81% of our patients achieve that. And when we look at a nationwide database, roughly 76% of patients achieve that, right? So that, again, another marker that patients are doing well, and we're reflecting that in the care we provide our patients. So one of the things that I think a lot of our patients appreciate is not only being alive and feeling well, they want to stay out of the hospital. As much as they like working with us and us taking care of them, they'd rather not be in the hospital. So here we're looking at our data. So the light green bar is our NGHS 30-day readmission rate. So how many of our patients leave with an LVAD and come back within 30 days? Happy to report that's roughly 13%. Now, nationwide, that number is double that. It's close to 30% of patients leave and come back within that time. So again, this speaks to the multidisciplinary nature of this program and really all the work we're doing as a team to help patients feel better and stay out of the hospital. Now, when we look at the KCCQ score, keep in mind, this is a score that underlies how patients perceive their own quality of life. And as we can see, when we look at our implants in our system, those numbers go up gradually as well. And we have a 20+ point increase for patients who've been implanted at our center. So we're seeing that improvement in quality of life as well. Other metrics that we've looked at and that we're really proud of and want to highlight these is, for example, one of the problems we have with LVADs is related to driveline infections, right? So we've got this metallic tube that comes out and connects to the battery system. Those things can become infected. Well, in our system at 3 months, less than 1% of patients have any issues with infection. The national average is roughly 3 times that, so it's about 3.4%. When we look at a risk of pump thrombosis or the pump not working well, we've had 0% of our patients have any issues related to that. And nationwide, that number is close to 7%. Looking at a risk of bleeding, right? So patients have these pumps and they're anticoagulated. There's a risk of bleeding that could come with it. None of our patients have had GI bleed within that 3-month mark. And nationwide, that number is about 12%. So really, I think what this represents is what we've done as a health system and really pulling together all our resources and working in a collaborative manner to ensure that the patient has the best possible outcome once the pump goes in and continuing that care. So we're really proud of this data. And again, wanted to highlight that for everyone to be aware of it. So again, having said that, it ultimately takes a team to get this done. This is not a one-man show or a one-woman show. This is a service line and a cure that everyone eventually touches these patients in one manner or the other. And I've kind of put up a quick list here. I'm sure I may be missing folks. But really, cardiac surgery, our heart failure team of finance, pharmacy, nutrition, anesthesia. Our administrators are a big part of this. We've got a quality team, a pastoral care, psychiatry. Our ecotechnologists are involved. So really, every aspect of the health system really comes to bear upon successfully implanting these patients. So this is where I'll leave it. And of course, a big and most important part of our team are the patients, and we're going to have a patient panel as a follow-up to this, where we'll delve more into that. But I'm going to pause here and see if there's any questions or comments.
If anybody has a question, I have a mic. Just raise your hand if you have a question.
So, Dr. Egolum, that was a great presentation. Thank you for that summary, and really kudos to you and Dr. Rajay and the whole team for really moving this program forward. And as you can see, some of you in the audience, it definitely makes a huge difference in impacting lives. I think one question that comes up is, given what you showed with respect to the guidelines, suggesting that, a lot more patients should be considered for LVAD therapy. And even though we're making a lot of progress and we've got a total of 55 patients, we've got a lot more patients with advanced heart failure, stage D, that potentially could benefit from it. So where do you see this going, and what needs to happen that more patients get access to this life-saving therapy?
Yeah, no, I think you've hit the nail on the head, and this is a big discussion point throughout most health systems, and especially among advanced heart failure cardiologists. When we're at our national meetings, this is always something that gets brought up. So I think internally for us, with Dr. Rajay, Dr. Costa, and myself, one of the things we work with our team is to make sure we're as available as much as possible, physically, and just doing this education over and over. I think opportunities like this are great. We have panel discussions with our cardiology fellows. We go out into the community and talk to our referring doctors and just really spreading the message. I think that's number one. And I think number two, several other things we're doing is starting to leverage our Epic technology. There's abilities to do population health management through Epic. So looking at ways that we can use the data we already have to sort of identify that subgroup of patients that likely would benefit, and then us proactively reaching out to the general cardiologist or whoever is managing the patient and saying, hey, look, we've not seen this patient as of yet, but based on the clinical indicators we're seeing, there's a big chance that this patient is headed down this pathway. Let us see this patient as early as possible. So those are some of the things we're doing at our level to really spread this message and get it out there as quickly as possible. But yes, there's a big opportunity, because I think there's a lot more patients that could benefit from this who are not. All right, any other questions? Any questions online?
I don't see any questions from our virtual audience.
Okay, perfect. All right.
Oh. Scroll up. Okay, I have a question for you, Dr. Egolum. Do patients keep this LVAD for life?
Yeah, so there's several circumstances under which a patient may have a heart pump or LVAD put in. So for some patients are on the road to a transplant, and sometimes we put the heart pump in to keep them well enough to get to the point of a transplant. So if they do get to that point, the pump is removed with the old heart and the new heart's put in. But some patients, especially folks that may be older, someone who's above the age of 70, 75, or for other reasons may not be a transplant candidate, then those patients get the heart pump in, and that's their destination or final therapy pathway. So that patient keeps it in until the end. All right.
That's the only
excellent.
question here.
I know that we're celebrating Valentine's Day here.
Yeah.
But I think while you're there, could you just briefly comment on some of the other advances, whether it's medical therapy for heart failure, just briefly, and what impact that's had on survival, whether
Definitely.
it's CRT or, even
MitraClip.
MitraClips and other things, just so that the audience can understand that even though this is a great opportunity, there are a number of other areas
Right.
that we're making progress on.
Yeah, no, that's a very good point, Dr. Samedy. So when we look at the whole gamut of heart failure care, there's several aspects that go into it, and really, I think that's one of the things that sets our group apart. That as Georgia Heart Institute, we really have all those resources to see what benefits the patients best. The baseline of all of this is always medication therapy, right? So we've got a clinic dedicated to that, making sure the patients get on medications, for example, sacubitril valsartan, otherwise called Entresto. And then another group of drugs, the SGLT2 inhibitor therapies. This is the Farxiga, Jardiance, and Befa, things of that nature. So these drugs are wonderful. They're really good at letting patients live longer, stay out of the hospital, and helping improve their quality of life. But, once we've had patients on medications and that no longer works and the patient continues to have symptoms, then there's any number of options that we may look at. Some patients may have a lot of leakage of their valve, for example, the mitral valve. So there's now an option where we can minimally invasively go in and do what we call a mitral clip procedure, where that valve is clipped. That reduces a lot of the backwards flow of blood and helps the patient actually have less symptoms and allows them to live longer. So we do have a structural heart institute as part of Georgia Heart. So Dr. Ramadan and his team frequently evaluate patients, and if they're deemed appropriate, the mitral clip procedure can be done in that regard. To that extent as well, some patients may have heart failure related to a lot of blockage issues, right? So sometimes it may be complicated, but we need to go in and fix those blockages. So we do have our complex interventional program with Dr. Henry and his team. They can look at patients and see, could we fix these blockages and help improve blood flow to the heart and improve the patient's heart failure symptoms in that regard as well. Some patients may not be candidates for stents to go in, but they may be a candidate for bypass surgery. So now we have Dr. Sloan on board, Dr. Sloan Guy and his team. They're able to do bypass surgery. They can actually go in robotically, make small incisions, and reroute some of the blood flow in the heart to improve blood flow to the heart muscle and help patients equally well that have heart failure related problems. So again, and I think the bottom line is, as we're making this decision, every patient is sort of unique, and we need to decide, well, which pathway does a specific patient need to go to kind of facilitate and give them the best outcomes. The other thing I'll add to, we do have a large research enterprise. So there are therapies that are coming, that are still been studied that may not be FDA approved as of yet, but with our large network of research studies, we're able to attract some of those research trials and have our patients actually have the option to benefit for some of these therapeutic interventions way before they get to market, if you will. One of the things I'll highlight, we did have an interatrial septal device. It's a small shunt device that we can put in the top chamber of the heart. It actually allows blood to go between both chambers and relieve a lot of fluid buildup and symptoms. So we've had patients from here who participated in those clinical trials, and they have done really well. So I think that's another thing we add as we see patients, we expand those options. So really, when a patient shows up here, they're offered a plethora of options, and we try to make the decision as to what's the best pathway and which way do we head with the patient. Question? Denise?
Dr. Egolum, out of all of the VADers out there, what is the potential for the VAD to ever be extracted or turned off? And is there a percentage that's shown nationwide yet?
Yeah, so I think what you're getting at is this whole idea of LVAD recovery therapy. Probably the center that has the most experience with this would be the folks in Utah. Dr. Dracos and his group has done a lot of studies on this. So nationwide right now, roughly 1% to 3% of patients get recovered to the point where the LVAD can be explanted. So that's a fairly low number. So what we've done in that regard, and some of my research when I was a fellow was around this topic, is we do have an LVAD recovery protocol. So for patients that have an LVAD implanted, when we're looking at our echoes, there's some labs we do. We monitor each patient at each visit to see if they're moving along that pathway. And if the patient is going along that pathway, we then have other, echoes and cath procedures and so on that we do to really assess and see if they have recovery. And we keep looking. We've not had one patient successfully get explanted yet, but we've had some patients have improvement. And we're monitoring closely to see if we get to that point. The other thing I'll mention in terms of heart failure therapy is what we call CRT device, so cardiac resynchronization therapy. So for a lot of patients who have pretty bad advanced heart failure, the left ventricle and the right ventricle do not correlate and come together as they normally should. So the heart sort of bounces a little bit, if you will. So our electrophysiologists who implant pacemakers are part of caring for heart failure patients. And for some subset of patients, they can go in and put in that specialized pacemaker defibrillator, and that can actually help improve the heart function, patient's quality of life, and how they feel overall. So that's another therapeutic option that we're able to offer.